Better. Okay, so still really loud. Are you able to turn it down up there, Gary? All right, so as we come down to our last few lectures, is that really loud to all of you still? It's okay? All right. Somehow for me it's booming. So just recently, actually, we realized in going through content outline for step 1 that the subject of neurocutaneous syndromes, which is a hot topic, and I think in talking with students, often a number of questions on this, is really not something that is covered adequately. I was assuming pathology was doing it, and anyway, they were assuming maybe neuro was doing it. So I've been looking for a way to push this into the curriculum, and so we're going to talk about it here this morning. And I think these are really, easy questions to answer if you've just kind of been through and have heard about the different syndromes. So we're going to talk about that. What I normally did in an hour on HIV and diabetes in terms of neurologic complications, I'm just going to kind of cherry pick what I think are the highest yield things. Okay, so what are neurocutaneous disorders? First of all, that's a defect of the primitive ectoderm, which gives rise to neurons, skin, so therefore we have kind of an overlap of nervous system and cutaneous problems. All of these are single gene defects, and there are many more than are listed in this handout. We're just going to go with the highest yield here. So these are autosomal dominant, recessive, and there's some X-linked that we won't talk about here in this lecture. Most of these fit under the general category of what's called a RASopathy. And what this means is we have RAS mitogen activating protein kinase, and normally these are involved in activating signaling cascades and stem cell factors. And so kind of the common mechanism for most of these and the genes for a lot of these neurocutaneous syndromes are called tumor suppressing genes, because the protein product normally quiets down this RAS MAPK. And so if you lose that, then you get dysregulation and tumors, and we'll talk about vascular abnormal growth and other things develop. So just as an example, neurofibromatosis type 1 is the most common neurocutaneous disorder. The protein here is neurofibromin, okay, and this acts for tumor suppression through suppression of RAS MAPK. So you lose that, and then you get a dysregulation. And so lots of tumors develop. Okay, so these are the ones that we're going to go through, and I'll try to make really clear what are the key points here to get out of this lecture, so we can see the inheritance, the chromosome, the gene, and the protein product. All right, so neurofibromatosis type 1. And again, I never ask you what is the incidence of a condition. This is just given so you have kind of a relative sense of what is more common or less common. So this is the most common, 1 in 3 or 4,000. Half are autosomal dominant, but the other half are just spontaneous mutations. And so they have characteristic skin findings. The first are cafe au lait spots. Okay, you can see these are hyperpigmented lesions. Okay, and so generally there are lots of these in type 1 neurofibromatosis. Okay, but we'll see there are other conditions that have cafe au lait spots, so you don't want to just equate, once you found cafe au lait spots, the patient has NF type 1. Okay, we can also see, not sure how well this shows up here, but it's called axillary freckling. This can occur in any crease area, so in the groin or inguinal area is another common place to have this freckling. So, you see a patient with a cafe au lait spot, you want to begin looking for other things. And this is one of the other things that you'd look for. Okay, now, I'll try to point out as we go through here, some of these have very specific findings, that if you see it, now it's more highly points to that specific condition. And for NF type 1, leash nodules are a specific finding. And so these are really iris hamartomas. Okay? Now, it might seem that, well, in this case, it's very obvious, but just with a routine, eye exam with an ophthalmoscope, these can be difficult. So if we have someone with that cafe au lait spots, we certainly would want them to be seen by an ophthalmologist. It often requires more detailed testing. to detect these, especially if they aren't as numerous or obvious as we see them here in this picture. Okay, and then they have the peripheral neurofibromas, and these are of two types. They can be cutaneous, and so we have here lots of cutaneous neurofibromas, and these can involve the face. These do not have any potential to have a malignant transformation at all, but obviously they can be disfiguring. Not too long ago there was a news story about the Pope who blessed and kissed a man here who had very extensive cutaneous neurofibromas. Okay, so more serious is what are called plexiform neurofibromas. And these are neurofibromas that grow along the course of nerves, the peripheral nervous system anywhere. This can be at the plexus level, but also peripheral nerves, nerve roots. And these are problematic, and they can have a malignant transformation, but even if they don't, just the growth can compress nerves and can cause weakness and sensory loss in that nerve distribution or plexus distribution. They can erode bone, they can compress blood vessels, they can cause all kinds of problems. Here's a young girl with a plexiform neurofibroma that began in the neck, I don't know, maybe root or plexus level, and it extended up through the neck. Here's the spinal cord. You can see this very extensive here. Ended up causing involvement of the internal carotid artery, the trachea, and up into the face. Okay, so these can be very difficult to treat, and obviously surgery is going to need to be involved with an extensive case like this. Okay, now here's something, just don't put a big star, make sure you don't miss this, because especially if you're a pediatrician and you have a patient with type 1 neurofibromatosis, kids especially are prone to get optic nerve gliomas. And there's some debate about, you know, how intensively do you screen these children for this, but especially up to the age of 6. All right, and so very important, once you've made a diagnosis of neurofibromatosis, they have to follow with an ophthalmologist. Okay, you want to do detailed screening. It probably isn't, some people would do this, but I think most do not just do routine screening MRI scans, although that's one approach, but at a minimum, regular follow-up with an ophthalmologist for early detection of any visual loss. And so these can certainly grow along the optic nerve, but sometimes they can start at the chiasm or even the optic tract, or sometimes even as far back as the optic radiations. Okay, so here is a patient with an optic nerve glioma. So obviously you want to detect these early because this is something that can be treated, but if it's not thought about, and children are not very good sometimes at reporting symptoms or having visual loss, and if that goes on for too long, it could be permanent. Okay, so that's very important for NF type 1. There are many, many other tumors that can develop, and I've decided not to list all of them, but there are lots of other tumors that can occur. But one thing worth knowing here is the dysregulation of blood vessels and vascular development, so a larger category of a vasculopathy, and this can lead to renal artery stenosis. These patients are more likely to have hypertension, cerebral aneurysms, and pheochromocytomas. Okay, these are tumors that are usually in the adrenal gland, and we'll actually talk a little bit more about those here in another neurocutaneous syndrome. Okay, there's a lot with these, and so it's sometimes hard to keep all of the different things straight, but because there's so many complications, NF type 1 tends to have a lot of musculoskeletal complications, so they tend to be short stature, have scoliosis, osteoporosis, and again, largely because all the tumors that can develop, they can have epilepsy and some cognitive deficits. Okay, so the skin findings, the leash nodules should be quite suggestive. Remember the optic nerve glioma, and then if you've got the cutaneous neurofibromas or plexiform neurofibromas, then the diagnosis usually becomes fairly obvious. So we can confirm this with genetics testing, but that does not tell you the course, if it's going to be a more severe or a mild course. So it just could help to confirm the diagnosis. And overall life expectancy is shorter for these individuals. So mid-50s is kind of an average life expectancy. And there isn't great data on this, but on death certificates, some form of malignancy is listed as most common reason for death. Now, one thing that is confused with NF type 1, because it has many of the same features, and I'm not going to go over all the fine details of this, but Legius syndrome looks a lot like NF type 1. They have the café au lait spots and lots of other overlapping features, but it's a mutation of a spread1 gene, okay, on chromosome 15. It has the same down pathway effect on the RAS system. Okay, so it's very similar. So if you have a patient, you think they have NF type 1, their genetics testing is negative, then you'd want to consider this as an alternative diagnosis here. And again, if you think of it, you can do the genetics testing for that condition. All right, NF type 2 is more serious than NF type 1. This is also autosomal dominant here in chromosome 22, and like NF type 1, only 50% of cases have a family history. Okay, the rest are de novo spontaneous mutations. You can see it's less common than NF type 1. Okay, and here the protein product is Merlin. Sometimes people still use the term schwannomen to describe the protein product. So again, this acts normally for tumor suppression. Okay, and so onset of symptoms are usually in the second or third decade. All right, so here is the, I would say, probably the highest yield board question of this whole section here, because it's such a specific finding for NF type 2. These patients have bilateral acoustic, or we can call them vestibular schwannomas. Okay, so if you're shown an MRI scan like this, so here's the cerebellum, here's the pons. Okay, we can kind of see the undersurface of the temporal lobes here. Remember the big connection between the pons and the cerebellum here is the middle cerebellar peduncle, so you can see that. And so we have these mass lesions here on either side at the cerebello-pontine angle. Okay, and so these usually start out involving the auditory nerve, so hearing loss would be common, tinnitus, ringing in the ear, and then the vestibular nerve is involved as well. So there's some dizziness and balance problems, just like you'd expect an acoustic schwannoma, but in this case it's bilateral. So if the patient has bilateral vestibular schwannomas, you want to assume they have NF2, certainly until proven otherwise. Now these can develop along other cranial nerves that are myelinated by Schwann cells. So 3 through 12 can all have these schwannomas. I think the facial nerve would probably be the next most common one that would be involved, but 8 is most characteristics. All right, a lot of tumors can develop, but maybe worthwhile just listing a little bit here for NF type 2. So these patients frequently have intracranial meningiomas and frequently have spinal cord tumors. And so these can be schwannomas, just like we see here in the brain of cranial nerves, but we can have ependymomas or meningiomas involving the spinal cord as well. And so, you know, schwannomas are benign tumors, but if they grow to a certain size, you can see, well, it's not hard to imagine that compressing the brainstem and causing serious symptoms. And likewise, if you have a meningioma or a schwannoma in the spinal cord, they're benign tumors. But if they're pressing the spinal cord, then obviously, you know, that has a devastating outcome. All right, so these patients can also have cataracts. So like NF type 1, both patients need to be followed with an ophthalmologist. They do have skin lesions, and they have tumors, both cutaneous and subcutaneous. They have café au lait spots, maybe in up to about 50%. They're a little different than the café au lait spots of NF type 1, but this is why I told you, don't just equate café au lait spots with NF type 1. You can see them in type 2 as well. Okay, and these patients often have peripheral neuropathy, which is a little difficult to explain because it usually isn't tumor pushing on the nerve. There's some other mechanism, and I won't get into all the details of that, but just to know that a high percentage of these patients will have peripheral neuropathy in addition. So poor prognosis. because of just lots of the tumors that develop in these patients. So mid-30s would be kind of an average life expectancy for NF type 2, but there is some evidence that if it's diagnosed early and we're really doing screening tests for tumors and treating, that that could be improved. And I think Dr. Deich has told you a little bit about pathology. What do you see with a schwannoma? Okay, and so I'm not going to try to pretend like I'm an expert here at looking at pathology, but I just thought I'd remind you of that. All right, so next to NF type 1, tuberous sclerosis is the next most common neurocutaneous disorder. And so these are, again, autosomal dominant. And so there are two genes for tuberous sclerosis. TSC1, which is on chromosome 9. The protein product there is hamartin. And TS2, which is on chromosome 16, produces tuberin. Okay, and so, there are some differences between these two. TS1 lesions are more likely to be familial and have a milder course. TS2 is more likely sporadic, but often have a more severe course. Okay, but otherwise, a lot of overlapping features between the two. All right, so in contrast to NF type 1, remember cafe au lait spots are hyperpigmented. In tuberous sclerosis, these are hypopigmented lesions, so they're called ash leaf spots. Okay, so we look for these. And also they have, usually in the face, a characteristic lesion here called facial angiofibromas. Okay, kind of seen here in the cheek area. But a more specific feature. So remember, for NF type 1, it's the leash nodules. For NF type 2, bilateral acoustic schwannomas. And here for tuberous sclerosis, shagreen patches, which are these, they're described as kind of an orange peel kind of texture to it, classically in the lumbosacral spine. Okay, this is a patient that had scoliosis, obviously, and surgery here, but this is a shagreen patch. Okay, so when we begin to see these, skin lesions, especially, if you're a pediatrician, you want to look very carefully everywhere, because in all of these conditions, there are clues that are found by more extensive investigation. All right, so the neurologic involvement in tuberous sclerosis, you get these tubers. That's where the name comes from. And tubers refer to an abnormal neuronal migration, and this results in what's called cortical dysplasia. And so notice here that we get these abnormalities here along the cortex here. This is the cingulate gyrus right here. And so it's some abnormalities out here in the Sylvian fissure. And so when you do an MRI scan in someone with tuberous sclerosis, you see these kind of cortical hotspots that will sort of light up. Okay, and the more of these you have, the more disability and problems these patients are going to have. Another characteristic lesion are subappendable nodules. So because this involves the ependema, they're going to be in the ventricular system generally. And so these can be quite problematic because they can transform into an astrocytoma that is called a subappendable giant cell astrocytoma. And so these can occlude flow of CSF and can result in hydrocephalus and can cause mass effect and all other kinds of problems. So because of the tubers and because of these subappendable nodules that can have kind of a malignant transformation, there's a high incidence of epilepsy. So usually these patients need to be on one or more anticonvulsants. Autism incidence is increased, and just developmental delay in general. So our pediatric neurology colleagues, I think a lot of what they do is in epilepsy clinic, treating these young kids that have epilepsy. Tuberous sclerosis, would be one of those more common situations. Okay, in the eye, patients can have retinal hamartomas. Okay, so again, ophthalmology is going to be involved in most of these neurocutaneous syndromes. And they can have other tumors. And so these are characteristic just for tuberous sclerosis, or much more common, involving the kidney or the heart. And so this is a patient, we're looking at the kidneys here, that has extensive angiomyolipomas here involving the kidneys. And so when we've diagnosed someone with tuberous sclerosis, we do, well, I don't treat kids, but what is done is regular MRI scans of the abdomen, because you want to try to pick these up at an early stage. And likewise, because cardiac rhabdomyomas are common, they need to follow with a cardiologist and have regular EKG studies, cardiac echo, to try to pick these up at an early stage. So early detection does make a big difference in clinical outcome. All right, Sturge-Weber syndrome. This is a sporadic condition. The mutation is the oh my. Do I acknowledge it? Let's see. Okay. Oh, I didn't look at the alert. Was it something bad? I just assumed it was a technical. Okay. Was it something bad? Did anyone read? Flooding. Okay. All right. That probably stopped the recording, but we'll see. Okay, so Sturge-Weber syndrome. So GNAQ gene, chromosome 19, and this one is very important for normal vascular development, and so therefore vascular obvious changes like this are the obvious feature in Sturge-Weber syndrome. All right, so this is called a port wine stain, which more technically is a facial capillary malformation. It's usually in the V1 distribution, but can be in the V2 distribution. Just to remind you here of, again, a nice drawing just done a few weeks ago by a fourth-year student. So this is certainly V1, but you can see that there's certainly some V2 involvement. So around the eye here would be kind of most characteristic for a port wine stain. And so this does not make a diagnosis of Sturge-Weber syndrome. It's a spectrum disorder. So the mildest form of mutation of the GNAQ will give you a port wine stain, but we don't use the term Sturge-Weber unless there is more extensive involvement of the eye and the brain. So just this in isolation, our diagnosis would be port wine stain or facial capillary malformation, not Sturge-Weber syndrome. Okay, so Sturge-Weber basically involves that capillary malformation moving back into the eye and to the brain. Now we use the term Sturge-Weber syndrome. And so here on the left hemisphere, okay, this patient has a port wine stain on the left. And so you can see that atrophy of the left hemisphere and this what's called leptomeningeal enhancement, which just reflects this capillary network here involving the brain, right? So there's some calcification. This is an MRI scan, so we don't see calcification very well on an MRI, but if you were to do a CT, you would see that. And so because of the progressive atrophy, degeneration of the hemisphere that's involved, these patients, they kind of have like a progressive hemiplegia. Sometimes it can appear even like stroke-like episodes. And anytime you've got something this severe involving the cortex, epilepsy is going to be almost a universal feature. So hemiplegia, perhaps contralateral to the port wine stain, seizures, and obvious cognitive mental retardation would be expected features then if for the full Sturge-Weber syndrome. Glaucoma incidence is quite high in patients with Sturge-Weber syndrome. And interestingly, this doesn't often even correspond to the side of the port wine stain. So again, patients need to follow with an ophthalmologist. Kind of seems to be a common theme here for all of these. All right, ataxia telangiectasia is a very nice term here because it tells you the classic features of this condition right there in the name. So this one is autosomal recessive, chromosome 11, and it's the ATM gene. So the protein here is the ATM protein. And this is a kinase. The ATM kinase seems to be important mainly for shutting down cell cycle progression when there is abnormal DNA. Okay, and so obviously losing that ability then creates the problems of ataxia telangiectasia. The ATM gene and protein is also normally involved in suppressing the BRCA1 protein. Have you heard of that? Yeah. So, and that's why we'll see that ataxia telangiectasia is also linked to breast cancer. Okay, I think a little typo in your handout. So the incidence is 1 in 20,000 to 100,000. But again, don't spend any time trying to remember that. Okay, so as the name indicates, ataxia. And so if we just look at a sagittal section of the brain, what should stand out here is, so let's just notice here, first of all, that on this image, CSF is dark. So fluid is dark. And so look at all this space, fluid space around the cerebellum. Cerebellum should occupy all of this. So we have very severe cerebellar atrophy. And so progressive ataxia is probably the initial feature in this condition. And then to remember what would be the other symptoms. If you can remember the cerebellum and what happens if you have problems with the cerebellum, then maybe you don't need to memorize this. So the cerebellum is involved in coordinating eye movements, right? So these patients don't move their eyes very well. They're probably going to have nystagmus. The cerebellum is important not just for coordinating arms and legs and balance, but coordinating fluency of speech, just, you know, kind of the rhythm of speech. So these patients have a dysarthria. Cerebellum coordinates all movement, including swallowing. So dysphagia is something that will be a feature of a severe cerebellar condition like this. Okay, so presentation then is falling, ataxia, eye movement problems, dysarthria, dysphagia. Okay, the whole brain's affected as well. So there is a progressive cognitive decline for these individuals. All right, telangiectasias. So these can be present in many locations. Here we can see a telangiectasia here in the eye and in the neck area, but most classically bulbar. Remember when we use the term bulbar, we're thinking about talking and swallowing. And so we look in the mouth, and here we can see telangiectasias involving the tongue here in this individual. Yeah, it's a strange picture. So again, cafe au lait spots, although the characteristic feature of NF1, you can see these in others, including NF2 and ataxia telangiectasia. So this is not a specific finding. And you can also have these melanocytic nevi as well. So the immune system, and I don't think this occurs with the other neurocutaneous syndromes, so maybe a unique feature of ataxia telangiectasia, they have a severe immune deficiency. Again, as a result of that inability kind of to shut down abnormal DNA, damaged DNA sequences in the cell cycle. And so these patients tend to get a lot of infections. They tend to be mainly respiratory and sinus. So as a physician treating a lot of pneumonias and sinusitis in these patients, that usually is the cause of death in patients with ataxia telangiectasia. And an increased risk of a whole host of malignancies. So these would be probably the three most common: lymphoma, leukemia, and breast cancer. All right, so again, a poor prognosis, just a devastating condition. So death usually in mid-20s overall. All right, and then the last one I'll mention here is von Hippel-Lindau syndrome. The pathophysiology is very complex, and I've chosen just to leave it off because I think I'll tell you what I think you need to know about von Hippel-Lindau syndrome. So it's divided into a type 1 and type 2. Type 1 has a relatively low risk of pheochromocytomas and renal cell cancer. Type 2 has a higher risk of both. Okay? And so the classic feature here are hemangioblastomas. And these are generally present in three areas. In the retina, so again, ophthalmology is important for these conditions, cerebellum, and in the spinal cord. And so here is a horizontal section of the brain. Here's the pons, here's the cerebellum. And so we have a lesion here, and it would be hard to tell just from looking at this to say what it is, okay, but a cerebellar location is classic for this condition. So they get hemangioblastomas throughout, and these are neoplasms that consist of capillary vessels. And there are a lot of nuance about how to treat and when surgery or other modalities can be helpful, which you don't need to know. Okay, but presentation usually in the third decade. I'm trying out some new PowerPoint features here. So these patients, as I mentioned, can have renal cell, and I just typed that in and the kidneys showed up, so I thought that was pretty good. So the two tumors that are be most common here are renal cell carcinoma and pheochromocytomas, which are usually of the adrenal gland. And just I thought worthwhile knowing that if you diagnose a pheochromocytoma in someone under the age of 18, half of those patients are going to have von Hippel-Lindau syndrome. Okay, so especially in a young patient population, we'd want to make that association. So pheochromocytomas produce catecholamines. So just imagine, you know, all this norepinephrine, epinephrine production here. And so the presentation of pheochromocytoma would be tachycardia, hypertension, sweating, again from the autonomic activation, and mood changes, you know, anxiety, certainly if there are spikes in catecholamines. And so we can screen for this by checking norepinephrines, which will allow us to assess norepinephrine production, and metanephrines, which has a decent sensitivity and specificity for this. Okay, so these would be kind of unique things here for von Hippel-Lindau syndrome. All right, so that was a quick run through. Do you have any questions about neurocutaneous syndromes? So hopefully you'll get a few more board questions right here. Now let's just talk a little bit about diabetes and HIV. And again, I'm just picking here what I think would be the highest yield. We talked a lot about diabetes and incidence of stroke, peripheral neuropathy, carpal tunnel syndrome that are all related to diabetes. But two other unique things that you should know about diabetes and neurology. One is infarction of the third nerve is a fairly common complication of diabetes. And so we've listed a number of causes of third nerve palsy. In my last lecture to you here, we're going to summarize those 5 causes of third nerve palsy. Okay, but here is one that has a very unique finding. So, you know, we've got a patient that has severe ptosis. We can see the eye is down and out. So we would suspect that this is a third nerve palsy. Okay, but what is unique about third nerve palsy, unlike all of the others, is that the pupil is spared. Okay, so you have to remember that. It's a pupil-sparing third nerve palsy. And the reason the pupil is spared here is if we just look at the third nerve, okay, the parasympathetics run out around the periphery of the third nerve. Okay, and remember the parasympathetics, that contains the Edinger-Westphal nucleus contribution to the third nerve. Remember, that's the parasympathetic contribution to the third nerve. It's trying to constrict your pupil. Right? So if we have a compressive lesion, like let's say this is a posterior communicating artery aneurysm, or maybe uncal herniation, well, the parasympathetics are going to be involved very early. So we're always going to have a big dilated pupil with a compressive lesion. Okay? Ischemia tends to involve the small penetrating blood vessels. So we're going to have involvement of the center of the nerve with relative preservation out here. Okay? So that's why it's pupil sparing. So really, if we see someone with diabetes that has a pupil-sparing third nerve palsy, we typically are not going to do a big workup, you know, for aneurysm or tumor compression or things like that, because the diagnosis is pretty clear. Usually the prognosis is pretty good. So even someone that looks like this, you see them a few weeks later, now the eye is open, they're able to move, you see them a month or 2 later, and oftentimes they'll get back to normal. All right, so that's a unique feature. So here's a patient. Now the eyelid, you can't see this as being lifted up by the thumb, so you can't appreciate the ptosis, but this patient has a right third nerve palsy. And so notice that when the eyes appear conjugate is when looking to the right, because the lateral rectus is 6th nerve, so the abduction is no problem. But now when this patient tries to look to the left, since the medial rectus is supplied by the third nerve, now the disconjugate gaze becomes very obvious. Okay, and in all other directions of gaze, trying to look up, you know, superior, inferior rectus, so we have a disconjugate gaze there, looking down, Again, dysconjugate gaze. So the only time the eyes really track together and the patient isn't going to have double vision is when they look in the direction of their third nerve palsy. So the right third nerve palsy looking to the right, now the eyes are pretty conjugate. Okay, and I'm sorry, you can't see that well enough here to appreciate that the pupils are actually symmetrical here in this picture. All right, the other unique complication of diabetes, it's called diabetic amyotrophy. This is a bit of a frustrating condition. It has about 7 or 8 different names, but I think this is the one that neurologists generally like to use, diabetic amyotrophy. And this one is very unusual for a couple of reasons. It doesn't correlate with severity of diabetes. Every other complication of diabetes, it's the worse your sugars are, the more likely you're going to have the complication. That's fairly obvious. That rule doesn't hold true for this condition. We don't know why. So you can have a patient with just well-controlled type 2 diabetes, sugars aren't out of control, patient is compliant, and they can still have this complication. And so the etiology here is ischemic infarction of the L2-3-4 nerve roots. Okay, and so again, why those nerve roots? I don't have a good answer for you, but those are the selective nerve roots that are involved in this. And so it presents like a radiculopathy. Okay, you might think, well, this is maybe a disc herniation or something. And so the patient has fairly abrupt onset, usually pain in the thigh and the hip area. They have weakness in proximal muscles because, remember, L2-3-4 nerve roots supply mainly muscles above the knee, so it's proximal weakness. All right, and so we think the patient has a radiculopathy. We send them off for an MRI scan, and it's pretty unremarkable. And this in itself can be tricky because no one over the age of 65 has a normal MRI of their lumbosacral spine. So you have to kind of use some common sense here. But we don't see a big disc extrusion with nerve root compression. And so if that's the case, patient has diabetes, we've ruled out a structural lesion, we assume the patient has diabetic amyotrophy. And because kind of the rule of thumb with nerve injury is if you injure a short nerve, prognosis is pretty good. The nerve can regrow, it can resupply muscles. And so fortunately, there isn't a long distance between the L2-3-4 nerve roots and the muscles. So the quadriceps and all of those, we get pretty good resupply of those muscles. Okay, if this were ischemic infarction of the S1 nerve root, well, that's the foot and a lot of distal muscles, then the prognosis wouldn't be so good. All right, but these patients, usually over a year or more, pain goes away, strength comes back. So like pupil-sparing third nerve palsy, it's a good prognosis. Okay, so here's another nice student drawing. Here showing some neurologic complications. We talked about stroke. I didn't go into some of the metabolic issues of diabetes, but cord infarction. Here's diabetic amyotrophy, L2-3-4 nerve roots, peripheral neuropathy. Remember, autonomic nerves are frequently involved in diabetes. Carpal tunnel syndrome incidence is much higher in diabetes. And there's our pupil-sparing third nerve palsy. Okay, well, let me just pick in 10 minutes here the highest of the high yield here for HIV. So first of all, we have dementia, which is called hand syndrome, HIV-associated neurocognitive disorder. And so overall, this occurs about 12% of patients that have advanced HIV or AIDS. Now, 30% of patients with AIDS will have some cognitive impairments. So everyone that has some memory loss that is HIV positive or that has AIDS doesn't have this syndrome. So the hand syndrome is a much more severe form of this. Now, this is older terms, but I'm telling you just because a lot of people still use this. It's sometimes referred to as a subcortical dementia. And when you hear that, you should think of a more withdrawn, depressed appearing demented individual. And usually they have features of Parkinsonism. All right, and so they're kind of shuffling as they're walking in. They don't move a lot. They appear withdrawn and depressed, and oftentimes there are a lot of behavioral changes along with this. But there are prominent very prominent cognitive deficits. And so this is severe condition, not a good prognosis, and they kind of, look eventually like a very end-stage Alzheimer's patient. So the most important thing that I want you to hear about this is when you have someone who's HIV positive, and especially has AIDS, that is having cognitive issues, they need a big workup. I can't outline all of the possible things that can happen, in the brain. It's a huge list, but we diagnose this by excluding everything else. And so these patients always need an MRI scan. I should add here with contrast, because that adds to your sensitivity of picking up things that could happen in the brain. So that would always be indicated. And if we don't have an obvious cause, from the MRI scan, then we're going to do a lumbar puncture. So I would say a lot of the lumbar punctures that we do are in patients who are HIV positive. We're looking for something infectious, that could potentially be treated. Okay, so it's a diagnosis of exclusion. We do a big workup and some other things here, but this would probably be the two of the high yield things for neurology that we would do for these individuals. All right, toxoplasmosis and encephalitis. Amazing, this is seen in 30% of individuals who have a CD4 count less than 100. So we really want to be primed for this in our very immunocompromised AIDS population. And so if you have anyone with a CD4 count under 100 and they're having lots of central nervous system problems, just assume this is the diagnosis until proven otherwise. And so they can have a lot of things. It's an encephalitis that involves the brain diffusely. And so I wouldn't try to memorize all of the potential things that can happen here, but if the motor cortex is involved, well, they're going to have weakness, hemiplegia. If the language areas are involved, they'll have aphasia. And it's an encephalitis, so we have swelling of the brain. It's an infectious condition, so they have a headache, fever, they're confused. Okay, and so I just include here the long, litany of things that can happen if the brain is diffusely involved. You irritate the cortex, patients are going to have seizures. Cranial nerves can also be involved in toxoplasmosis. If we have involvement of the optic tract or radiation or occipital lobe, they'll have visual field deficits. If sensory cortex is involved, they'll have maybe a hemisensory loss. And so just a long list of things. Again, I wouldn't try to memorize, but you just imagine the brain being active by all of these inflammatory areas that are occurring in kind of a quick, stepwise manner. So when we have a patient like this, of course, we want to get neuroimaging very early, and so MRI or CT will reveal these multiple ring-like enhancing lesions. So when we see that, we can be quite suspicious that the diagnosis is toxoplasmosis, encephalitis. Interestingly, these lesions often involve the basal ganglia as well, so we can see kind of deeper down here, even in the thalamus. Okay, so kind of diffuse involvement. And we can confirm this, but this takes some time by checking IgG antibodies. This needs to be done on the cerebrospinal fluid and PCR. But the culture, really confirmatory here, takes 6 weeks. And so that's a little bit of the dilemma. We're treating something we think the patient has, but there are other things that can occur in HIV that can mimic this. So sometimes we can't be completely confident for some time that this is what we're dealing with. Okay, so I won't ask you the antibiotic treatment, but just to know that there is an effective combination of antibiotics that can be given for this. And so patients usually turn the corner pretty quickly and start improving with treatment. Okay, so the important part B of this is what is the next most likely thing to be if it isn't toxoplasmosis? Okay, and the next most likely possibility is CNS lymphoma. So we kind of want to have these as our 1 and 2 most likely in this situation. So it has a lot of overlapping features with toxoplasmosis. And I'm going to try to highlight some of the differences, but just to know it isn't as black and white as I'll make it sound. It's often a little murky clinically. So in general, the progression is a little bit slower. with CNS lymphoma. They don't less likely to have a fever. But again, if you have someone with AIDS, they're prone to all other kinds of infections. So they may have a fever for some other reason. And so the CNS lymphoma is more likely to present as like a single mass type lesion, sort of like a tumor would present. And so we have increased intracranial pressure, which will cause drowsiness and confusion. They'll have headaches from that. And with any mass lesion, you irritate the cortex. Seizures would be a common presenting symptom. And if we involve the motor cortex, we might have some focal weakness. When you do a scan, it's more likely that you'll find a solitary lesion. Okay, it's not always true, but more likely that you'll have a solitary lesion like this instead of the multiple ring-enhancing lesions of toxoplasmosis. Okay, but the rule is if we're treating someone, we think they have toxoplasmosis encephalitis and they're not getting better, that should just be a big red flag. Well, maybe we're actually treating the wrong condition. Maybe it's actually lymphoma. And so when we're dealing with lymphoma, the patients need steroids, radiation treatment, and I won't go over the extensive antiretroviral regimen for these patients, which is called HAART. Okay, but if nothing is done, survival is only about a month. If we give radiotherapy, 2 to 5 months. And if you include the more extensive therapy here, 18 months. So kind of the usual situation here is we think we're treating toxoplasmosis, patient's not getting better, and then we begin to think, well, maybe it could be something else. And lymphoma, often you do need to biopsy to confirm the diagnosis. So again, it's distinguishing features, a little bit slower onset, no fever, more likely a single lesion, and your patient is not responding to therapy for toxo. All right, PML we have talked about a number of times, but very important that you associate that with HIV. And remember the medication for multiple sclerosis, natalizumab. Okay, so this is activation of the JC virus, common virus, but it's problematic only in the immunocompromised situation. So the classic thing about PML is it involves the optic radiations. So the presentation is usually visual loss, okay, and it's progressive. So, might start out as a quadrantenopsia and then progress to a homonymous hemianopsia, and then will spread to involve larger areas of the brain. Okay, so eventually may involve the motor and sensory cortex. So patients are eventually just overwhelmed by this, but the key thing early on is you want to remember that visual loss. Okay, and anytime large areas of the brain are involved, not surprising that we're going to have cognitive and behavioral changes. So I've shown you this picture before here of a patient with HIV who just had early, looks kind of like demyelination here of the optic radiations. So they did a biopsy here, and over time, this just grows. And as this extends forward then, you're going to have involvement of the motor and sensory cortex. Okay, so it's a clinical diagnosis supported by typically MRI findings. We sometimes will do a biopsy of this, hoping that maybe it will be something else because we really don't have any treatments for PML. We usually will do a lumbar puncture. We just have a very low threshold for doing that in our HIV population, hoping maybe we'll find something infectious that can be treated. But again, prognosis here, and this, if we finally concluded it's PML, it's a dismal prognosis. Okay, now I do have the, in your handout, vacuolar myopathy related to HIV. I'm not going to ask you about that, all right? So we're going to skip over that here because I did want to cover here would be the other super high yield thing to remember. So neurosyphilis is something today that we mainly see in the HIV population. And I'm just going to point out one thing that would be a classic exam finding in neurosyphilis. And remember in the spinal cord lecture, we talked about the posterior columns, tabies dorsalis. So that would be one classic feature of neurosyphilis. Another would be involvement here in the pretectal area of the midbrain. Okay, and from the first year, what was another condition we talked about that can do this? Parinaud syndrome. Remember, the pineal gland sits right here. And so Parinaud syndrome would have some overlapping features here. But the Argyll Robertson pupil refers to, let's just say normally you shine a light in the eye, and remember this goes through the lateral geniculate nucleus to the occipital cortex for vision. But for the pupillary light reflex, this enters the pretectal area to activate the Ettinger-Westphal nucleus, okay, which goes out to the pupil through the ciliary ganglion. And I wish this were drawn on both sides, just to emphasize that both pupils constrict to light. And so the problem with pretectal areas, and it's really hard to understand exactly how this happens, but there is a different innervation of the pretectal area here from the visual cortex. And so there's a discrepancy between how pupils react to light and how they react to accommodation, which is looking towards your nose, because that will also normally, when you do that, that requires connection between the visual cortex and the pretectal area to constrict your pupil. So there's a disconnect between those two pathways. And so in Argyll Robertson pupil, the pupils do not constrict well to light, but they do constrict well to accommodation. And so if you see that kind of discrepancy, you're always wanting to put the lesion right here. Okay, and so the two things here from last year, Parinaud syndrome can do that. And if we have this, certainly in a patient who is HIV positive, then we're going to assume this is related to neurosyphilis. Okay, so let's stop there, and we'll have see you, I guess, tomorrow morning for our TBL.